Hello, everyone, and welcome to the Diplomat Health Conference. I'm Anna Gawel, Managing Editor of the Diplomat. I want to thank everyone, of course, for joining us on the second day of our conference. I also want to take a moment to thank our sponsors who helped make this event possible. Cigna, Children's National Hospital, the George Washington University, Kaiser Permanente, Home Care Connections, and Jan Duplain Enterprises. You can learn more about our sponsors by clicking on the Expo Booths button on your left-hand side. Also, if you just saw on the video, you can at any time click the networking button, and you'll be randomly paired with another participant. You can chat for 3 minutes, and if you want to extend your conversation, just hit the extend button, and to exchange profile information, hit the connect button. So that's a fun feature I encourage you to try at some point. But in the meantime, we've also got some great panels. Now, yesterday we covered a lot of ground, from the White House's vaccine strategy to mental health and well-being during this pandemic, to learning about some really fascinating innovations in fields such as cardiology, oncology, and telemedicine. So today we have another diverse lineup of panels that will explore COVID's global impact, the top medical institutions here in the US, and how foreign governments can establish partnerships with those institutions. But first, we are going to revisit the issue of coronavirus and healthcare issues in general under the Biden administration on both a local and a national level. So I wanted to welcome our first two panelists. They can go ahead and join us. Hi there, Danny and Matt, if we could have you pop in. Great. So just some quick introductions. To give us the local perspective, we have Dr. Danny Avula. He is director of the Richmond City and Henrico County Health Departments, who in January was tapped by Governor Ralph Northam to lead the vaccination program for Virginia. So he's also a public health physician who is board certified in pediatrics and preventative medicine and continues to practice clinically as a pediatric hospitalist. So welcome, Danny. Thanks for joining us.
Thanks, Anna. Great to be here.
Thanks. We also have Matthew Fiedler, a fellow of economic studies with the USC-Brookings Schaeffer Initiative for Health Policy. Prior to joining Brookings in 2017, he served as chief economist of the Council of Economic Advisors, where he oversaw the implementation of the Affordable Care Act and its health insurance expansions and delivery systems reform. So, hi, Matt. Thank you for joining us as well.
Thanks very much for having me.
So, Danny, I'd like to start with you and the topic that was raised yesterday, which is the revised CDC guidance lifting mask and distancing requirements for fully vaccinated people in most situations, including indoor settings. The announcement took many people, reportedly even the White House, by surprise after months of, what many said were CDC guidelines that were overly cautious. Virginia and Maryland promptly followed suit, dropped their mask mandates, except in certain situations such as schools and healthcare settings. But the new guidelines are essentially for now based on an honor system. So unless, businesses, for example, begin checking people's vaccination status, technically anyone can take off their masks in settings like restaurants, grocery stores, theaters. And these are precisely the indoor settings where we've learned that the virus can now remain airborne for periods of time, regardless of social distancing. And so, therefore, masks were really an important form of protection. So, Danny, let's start. How do you address the criticism that lifting these mandates was premature and that it could lead to two related problems? One, outbreaks among the still significant portion of the population that is unvaccinated, and two, potential problems spilling over even for those who have been vaccinated because of issues like herd immunity and the threat of variants.
Yeah, I think it's probably a good place to start is to think about what the role of the CDC has been and then what the role of states and localities are in this pandemic response. The CDC's role so far really has been to gather the science and to make recommendations based on the science. And that's exactly what they did. They saw the mounting evidence over the last few months that vaccination is incredibly effective. I mean, at some point last week or the week before, we were looking at CDC data that showed 95 million Americans who are fully vaccinated, so 1 or 2 weeks out of your final dose. And of that 95 million doses, only 9,200 breakthrough cases. So like a real world effectiveness of 99+%. And each study that has been done has showed more and more that people who are fully vaccinated are at very low risk to get infected and even lower risk to actually potentially transmit the disease, which is why, when those final studies came in this past week, the CDC said, all right, this is what we need to feel good about recommending that people who are fully vaccinated no longer need to wear masks. Mm-hmm. Now, the tricky part is that the CDC isn't legislating this for the entire country. The CDC is saying, here's what the science is saying. You all should figure out what to do with it now. And so that's fallen on us as states and localities to say, okay, given this guidance, how do we now tweak our policies and our practices at the state level? And so, it definitely caught us by surprise, because I think the general public doesn't understand that, right? Like, they hear the CDC says you don't need masks anymore. And to the public, like, that translates immediately to, all right,
we're done.
And we'll take time for that to translate into actual policy. So, that 24-hour period here in Virginia, working with the governor and his team to figure out, okay, what does this mean? What does it mean for the mask mandates we have in place? What does it mean for the social distancing requirements that have been written into our emergency code? And what do we need to pull back on? And so within 24 hours, we kind of looked at the impact of the recommendations. We looked at our existing policies. We decided immediately to come into alignment with the CDC recommendation that people who are fully vaccinated no longer have to wear masks. And then that did translate to the policy change that we lifted the mask mandate. And that's where it gets tricky, because we are really relying on Virginians to do the right thing, to follow the guidance, to, if they're fully vaccinated, to enjoy that freedom. If they're not, to continue wearing masks. But how to translate that into policy it becomes really laborious, right? Like, are we going to expect every entity, every office, every business to require a proof of certification? I just think about, your frontline grocery store worker. Are you really going to have them ask for certification and then, to bar somebody from entering without a mask? So it's a pretty tough thing to operationalize, which is why ultimately we just said, okay, we've got to remove the mask mandate, encourage Virginians to do the right thing, and keep pressing into vaccinating as many people as quickly as possible. Mm-hmm,
mm-hmm. Well, I mean, and you brought up the point, and obviously, this is really tough for businesses. It's also kind of a patchwork, as you said. One state is doing this, one county is doing this, and it's difficult also, I'm sure, for a business where next door there's no mask requirement, but you've chosen to require masks because your employees are concerned. I mean, do you have any kind of practical advice? The issue of masks has also become very politicized, as you know. Do you have any kind of practical advice for businesses who are trying to navigate this messaging and these guidelines?
Yeah, I mean, it's going to vary so much regionally, because as you just said, I mean, this has been really politicized. There's the culture of a community that drives adoption of these practices in so many cases. And so there are rural parts of our state. People probably haven't been wearing masks for most of the pandemic, and local business owners have probably just turned the other way despite the mandate, despite the regulations that we've advanced. So, I mean, I think for businesses, I actually do see a lot of businesses that will continue to recommend mask wearing, or even require mask wearing, or have some kind of certification. Some have already done this, right? Airlines require either a proof of vaccination or a proof of a negative test. Cruise lines are doing the same. So I absolutely think the private sector will, based on its clientele, will likely adopt some of these practices of either continuing everyone to require masks, less likely, more likely requiring some proof of certification. I think the other thing to think about is in the context of your business, whatever it is, are there scenarios that are higher risk than others? So if you are a theater and that is an indoor situation, you have a bunch of people who have a extended duration of time, right? I mean, that's the highest risk situation for transmission of COVID. That might be a scenario where the theater says, you know what, regardless of whether you're vaccinated or not, we want masks to minimize the risk. Or they might go the other way and say, hey, we're going to require proof of negative testing and proof of vaccination. Other businesses like, a restaurant who has a lot of outdoor seating, or a department store where people aren't really congregated for extended periods of time, they may be more flexible and really just ask, again, that people do the right thing and follow the guidance. So I think it's really going to vary widely based on region, culture, and context.
Yeah. No, and of course it's incredibly nuanced, and as you said, everyone has a very particular situation, so it's there's no one right or one wrong answer. So Matt, I want to switch gears and go over to you and more your specialty, which lies more in the federal realm. Now, over the last decade, as you know, there's been no shortage of predictions about the imminent demise of the Affordable Care Act, otherwise known to many people as Obamacare. Yet it has survived legal challenges going all the way up to the Supreme Court. Multiple GOP attempts to kill it. Most recently, the Trump administration vowed to repeal the law and replace it. That's been a longstanding pledge of Republicans, although there has not been any concrete alternative offered to it. But on top of that, we have the pandemic, which in a sense has strengthened Obamacare, with 1 million Americans signing up for health insurance under the law during a special enrollment period that President Biden enacted during the pandemic. And the president has vowed to build on the Affordable Care Act to ensure healthcare coverage for every American. Now, I know the law faces kind of one final legal hurdle at the Supreme Court at some point later this year, although so far the court has resisted completely dismantling the law. So with everything we've seen recently, do you think we can finally say that Obamacare is settled, it's the law of the land, and now it's more a matter of improving and possibly expanding upon it?
So, I mean, I think, the starting point that you mentioned is, what the Supreme Court does over the next few months. I'm cautiously optimistic that the court will leave the law in place. I think the sort of legal theory underlying this particular challenge is so absurd and so weak that the chances of success here are pretty small. And, when we listened to oral arguments at the court last fall, even some of the conservative justices were expressing quite a bit of skepticism about the arguments that were being made about why the law needed to be struck down. Looking ahead, I think the near-term policy agenda certainly is quite a contrast with the sort of debates over retrenchment we've had over the last, certainly during the Trump administration. And there's a lot of interest in building on the law in various ways. So in the American Rescue Plan Act, the COVID relief bill that was passed earlier this year, you saw a substantial expansion of the subsidies available to people who purchase coverage on the ACA's marketplaces. These are the marketplaces that were created for people who don't have access to public coverage and don't have access to coverage at work. So that was the first substantial sort of expansion of the Affordable Care Act that's been implemented during its time in existence. And I think will be an effort to make those changes permanent this year. And you could see some other changes as well that could sort of build on or try to move forward on some of the unfinished business of the ACA. Does that mean the sort of controversy and policy debates over the ACA are behind us? I think that's a harder question. I mean, I think there are some deep underlying ideological disagreements here about the role of the government in ensuring that people have health insurance and can access health care, and the role of tax dollars in making sure that that's possible. That I think are going to be with us for a very long time. So are we still, will we still be talking about repeal of the ACA as such? Next time there's a Republican administration and a Republican Congress, Maybe not, but will there be debates over whether we should reduce the subsidies available on the ACA's marketplaces or make other changes like those that were in the ACA repeal bills to Medicaid? I think it's entirely possible we'll be having those debates in years to come. And the reality is those sorts of debates are ones we've been having for decades, where Democrats have generally been in favor of expanding these types of coverage programs, and Republicans have generally been in favor of spending less on them, even if that means fewer people are covered.
Okay. Well, we'll get back to that issue, but in a sense, of course, this touches on the pandemic has exposed some of the access and equity issues in this country. Now, Danny, you had mentioned the improving metrics. I mean, just to give our audience an idea, in mid-January when President Biden took office, Virginia on one day reported over 7,200 coronavirus cases. As of May 19th, or on May 19th, that figure was about 454. We've seen hospitalizations, deaths, all community transmission, all go down dramatically. And the state is reaching the point, like the rest of the country, where half the adult population has received at least one vaccine dose. So, this is a dramatic improvement from really, not just 4 months ago, but even really a few weeks ago when people were, I know myself, were thrilled, like, yay, we got a vaccine appointment. Because it was a case of demand outstripping supply. And now we're transitioning, as you know, to the next phase where supply is outstripping demand, and officials are working to convince all Americans to get the vaccine. And people are hesitant or have refused to for different reasons. So what strategies have you employed to tackle this issue of vaccine hesitancy, specifically when it comes to one, communities of color, which have been impacted disproportionately by the virus, and also Virginia has a lot of rural communities where Republican skepticism of the vaccine tends to be high?
So, our mantra from the beginning, the nation's mantra has been, this effort has to be about efficiency and equity. We need to both get as many people vaccinated as quickly as possible, because there's this imperative to community immunity, to herd immunity, right? People vaccinated, the quicker we tamp down the possibility of COVID to continue spreading. But we also know that there are segments of our community who are inherently at higher risk, right? We've seen the impact of the pandemic from last March really disproportionately affect Black and Latino communities, in part because they are disproportionately working frontline jobs where they're, having to go out and actually interact with people as opposed to being able to do most of their work from home like I can. They are reliant on public transportation. They are densely packed in from a housing standpoint. You sometimes have multiple families living in a small space, which obviously is going to lead to more transmission once somebody gets infected. And there are inherent barriers to care for them. I mean, particularly for our undocumented community, who's going to avoid interactions with any kind of governmental entity as long as they can. So for all of those reasons, we saw this huge impact in case rates and subsequently in hospitalizations and death in our Black and Latino community, which is why from the beginning of the vaccination effort, we've said, okay, we have to be hyper focused on getting these segments of our community vaccinated. And so, we set clear targets for ourselves. We put those targets in front of our team at the state level, but also our local health departments. We have 35 local health districts throughout the state of Virginia. Every week or every other week, we have a team who's working with those local health districts saying, how are we tracking on these metrics? How are we doing in our Black and Latino populations? And the work has been really hard. Actually, in Virginia, we've done really well with our Hispanic Latino population. About 12.5% of the folks that we vaccinated are Latino, whereas only about 9.5% of Virginia's population is Latino. So we're actually overperforming there. And I point to a lot of the efforts that our local health departments have engaged in. They're going to employers that employ predominantly Latino or undocumented residents. They're going to the construction sites, to the restaurant industry. They're doing on-site vaccination. They are going to poultry farms and hiring community health workers or ambassadors that work in those settings to vouch for the vaccine with their peers. So a lot of different strategies we tried. I think the overarching point is that it's been incredibly intentional. We have not done as well with the African-American community. Virginia is about 19% Black. We're only about 14.5% of the folks we vaccinated who are Black. And so despite tremendous effort in that arena, from the beginning of this, partnering with the NAACP, partnering with churches and other faith communities to do on-site vaccination, we've seen those numbers lag. And so we continue to work with key leaders in those communities because so much of this is about trust. And there are myriad reasons why people don't trust this, whether it's the government's doing it, the government's working too hard to try to get us to do it, historical realities about how the government and public health have treated Black communities, and so on and so, and what social media has really driven, right? I mean, I've got a bunch of teenagers, and yesterday, the TikTok myth of the day was, if you get vaccinated, you become magnetic. And so there are all these teenagers who would like put a magnet on themselves and say, don't do it. So anyway, these are the things that we're fighting. But we have really worked hard not only to do the efficiency part, so to build mass vaccination centers in key parts across the state and really get the kind of throughput we've needed to get so many people vaccinated quickly, but simultaneously to do the mobile work, the pop-up work, the more partner-based work, and then to design our communication strategies in ways that reach minority communities. So we 3 months ago hired a Black-owned communications firm to really have that lens in everything that we're producing, so that it would be accessible to African Americans. We have a specific campaign that's going to barbershops and beauty salons. We have really tying the vaccination effort to our statewide equity agenda. And then we've also hired a Black-owned company that does canvassing, marketing, and outreach. And so they have been an integral part of our work in regions all over the state where they're doing the groundwork. They're out there canvassing, they're out there connecting with churches and other faith leaders. So it's been really intentional. It has been really difficult, and it's been a bit of a swing. I think at the beginning of this, we anticipated African Americans would have lower uptake rates. We saw the national survey data move from January to March, where African Americans actually moving quickly from wait and see to let's get vaccinated now. And now we're seeing it swing back, where we still have, at least in Virginia, a lot of resistance to vaccination. So it's an ongoing part of our work, but the intentionality and keeping the numbers in front of us on a daily basis has been a big part of that.
Yeah. And, and as you said, everyone from the local to national level has really put on their creative hats of trying to reach out to very distinct communities, and there are TikTok messages that are positive, pro-vaccine. And, when it comes to access issues, we've got Uber and Lyft providing free rides. So, it's been impressive to see. Now, Matt, though, this kind of does get to the larger issue, though, of these vast disparities that continue to exist. And, obviously, access to affordable healthcare was the driving force behind Obamacare. Now, in addition to some of the things you mentioned earlier, such as the subsidies in the American Rescue Plan, I just wanted to also note there are proposals in the President Biden's Families Plan, which includes health-related assistance, such as $225 billion toward national paid family and medical leave, as well as $200 billion to, continue some of the subsidies and reduce premiums. Now, Biden's plans so far have notably left out a longstanding Democratic proposal that would empower Medicare to negotiate drug prices directly with pharmaceutical companies in a bid to lower costs. This is something, obviously, that the drug industry has been dead set against. Now, the fate of a standalone drug pricing bill is very much up in the air, in part because of, fierce opposition from the drug lobby. So some Democrats have urged the president to include the drug pricing initiative in his family's plan and use the savings to pay for Medicare coverage expansion, such as possibly lowering the eligibility age. So, this is a long-standing debate of whether Medicare can negotiate directly with drug companies. What are some of your thoughts on this effort, and where do you see it going?
So, there's certainly a long discussion about whether Medicare should negotiate prices, but I think even more broadly than that, what prices should consumers both in Medicare and outside of Medicare and private insurance be paying for prescription drugs in the United States? And I think, that, and this, putting my economist hat on, there's like among economists, there's a big debate about what the right answer to that question is. Paying more obviously places larger burdens on consumers and on the governments who finance care. And the flip side of that is the way we create incentives to develop new drugs in our system is that we allow firms that develop new drugs to have a monopoly on those drugs and charge a fairly high price for some period of time. And so how exactly you strike that balance and whether the U.S. system is striking that balance correctly today is a hard question and a real trade-off. In terms of, so certainly, many Democrats are of the view that our system is skewed too far towards the high prices and that we're not getting very much in terms of innovation from those high prices. And so, you saw the House of Representatives over the last couple of years have passed very aggressive bills that would seek to reduce prices through negotiation, but also through putting essentially a cap on many of these prices at the prices that tend to be paid in other developed countries. I'm frankly skeptical that that type of approach is likely to be viable this year. I think the thin margins in the Senate make that hard, but also there's a number of House Democrats who have indicated that they're not really comfortable with that type of approach. And, there are probably a whole bunch of reasons for that. I think in some cases, these are members who have biopharmaceutical companies in their districts. And so they're very sort of attuned to the effects on the biopharmaceutical industry. I think in other cases, they may be concerned more directly about this sort of pricing versus innovation trade-off and where exactly they want to fall on that. All that said, I think it's entirely possible that there will be legislation of some form this year that reduces drug prices in some way. And I think the motivation for that will be exactly what you were alluding to, that there's something else that policymakers want to do, whether that be expanding the Medicare program in some way, or another policy that's certainly under discussion is filling what's called the Medicaid coverage gap. This is people who are below the poverty line in states that have not adopted the ACA's Medicaid expansion and so have no source of affordable coverage. There are other types of coverage expansions that people are interested in. And so I think that, may lead people ultimately to say, well, some drug savings are potentially attractive. And the question is just how deep will those savings be?
Right. So, Danny, I wanted to go back to, you were talking about some of the various strategies you've employed to kind of win over the vaccine skeptics or those who are hesitant. On that note, I know a lot of localities and the federal government is looking to now physicians, healthcare providers, really, the doctors who have close relationships with their parents to kind of achieve the administration's next vaccination target. But you yourself pointed out in a Politico article recently that it's not as simple as sending, your rural doctor's office a batch of vaccines. There are huge logistical challenges. Can you talk about some of those challenges and what are some of your strategies for trying to overcome them as you want to recruit more and more physicians in this effort?
Sure. Yeah, that was a point of contention at the beginning of this rollout, because immediately, every physician just wants to wants to help their patients. And so as soon as vaccines started flowing into the state, I was hearing from every statewide association of physicians saying, get us the vaccine, we can get it to our patients. And it wasn't until we started to break down the realities of what it means to be a CDC approved vaccine provider. You, particularly with the Pfizer product at that time, you needed ultra cold storage. The Pfizer, to keep it stable, had to be stored at negative 90 degrees Fahrenheit, which was much more colder than any standard refrigerator or freezer could keep it at. And so there was an upfront equipment cost to buy ultra cold freezers. Pfizer was also shipped in shipping trays of 1,170 doses. And so at the time, kind of mid-January, a huge part of our imperative was efficiency. We need to use, because there was so much dose scarcity, we needed to use every dose every week to get as many people covered as possible. And if you send 1,170 doses to a small practice, it may be weeks before they have the patient flow to be able to get that. Whereas we could do that. I mean, we could do multiple trays in a day in a large mass vaccination center. And that was a hard place for my colleagues. Despite talking through those realities, I think their desire to just help their patients was so overwhelming that they were really frustrated with the government for not allowing access. Over time, I think they understood, particularly because of the pace at which we've been able to vaccinate the masses. And my sort of constant engagement with them saying, you guys will play an incredibly important role in this. And that role is now. Over the last 3 weeks in Virginia, we shifted to this lots of demand and not enough supply to now lots of supply and not enough demand. And so that work with our practitioners, relying on the trust they have with their patients, relying on the ability to answer questions and reassure. All of our survey data shows that people are looking for guidance from their friends and family, foremost, by a large margin, and then from their healthcare providers. And so we've really re-engaged our providers and said, hey, you guys, this is your time, right? That right now we need you guys to help people who are hesitant. So a couple of practical things we've done. One, we have set up regional pharmacy distribution hubs where independent pharmacies and health departments receive those larger packages of Pfizer. They chop them up so that providers can order smaller amounts. So instead of 1,170 doses, if they only need 40 doses or just a couple vials, the health department or a pharmacy hub can redistribute to them. So that's one practical logistical thing we've had to change. Thankfully, the storage requirements have gotten easier over time. The more they study these vaccines and how stable they are in different conditions, we have more clarity about how long they need to be frozen versus refrigerated versus at room temperature. But the other thing we've done, and we're just kind of piloting it this week, is that that patient-doctor relationship is so kind of one patient at a time. And so what we've done is we've created a town hall, like a town hall in a box. So we've created the Zoom platform, a baseline PowerPoint presentation, and then a one-pager with FAQs for the provider so that they can get the information they need. And then we're asking physicians, hey, send this link to your patients. You can talk to 300 to 400 patients at a time through this venue. They can hear directly from you. They can ask correct questions directly to you. And so we'll see what kind of impact that has over the next few weeks as we expand its use here in Virginia.
Yeah, no, and it's interesting you say that because I think it mirrors a lot of people's experiences. I know one of the first things I did was, email my doctor, hey, what should I do? What should, I need it for this or that, and ultimately I, got it very efficiently through Six Flags, the max vaccination site in Maryland. I'm sure Virginia's are good too, but I'm a Marylander. So yeah, no, I mean, you can certainly see where that next step makes a lot of sense. Now, Matt, over to you. When we're talking about healthcare politics, at least within the Democratic Party, we obviously have a vocal progressive wing, and something people have now really heard of a lot and are hearing is the public option. And this is a subject you've written extensively about, which is, of course, using the public option to reduce healthcare provider cost. I know that it's an enormously complex topic to tackle. But, you've argued that the public option may not provide as many benefits as people think. So again, knowing it is a complicated issue, can you though explain some of your general thoughts on the public option and explain to our audience, some of its pros and some of its cons?
So, I think one of the things people who study the U.S. healthcare system that stands out very strongly is that different types of insurance pay healthcare providers very different amounts of money for the same services. So if you look at what a typical private insurer pays for healthcare services, that's often for hospital services, say, you're often talking about them paying roughly twice what, for example, the Medicare program, our program for seniors and people with disabilities, will pay for the exact same service. And so I think that leads people to say, well, what's going on here? And I think what's going on here is that in many cases, we have hospital markets in particular that don't have a whole lot of competition. And when they're bargaining with private insurers, that means that hospitals can often extract very high prices from payers that they're not able to extract from the Medicare program because the government sort of decrees this is the price that the Medicare program pays, take it or leave it. And hospitals say, well, it's above my cost of treating an additional patient, so I'll take it. It's better than not taking it. So I think that leads to a lot of interest in, could we, through a public option, get prices more like what Medicare does for the population of people under 65 who are covered by private insurance. And I think the answer is actually yes. So I may actually be a little more positive on a public option than your question suggests. But I think what is true is that public option needs to be designed in a very particular way in order for a public option to be able to get the prices that Medicare gets while still encouraging providers to participate. So in particular, if you set up a setting where a public option typically is envisioned that it would compete alongside private insurers, if providers have the option to say, well, I'm going to continue seeing patients who are privately insured, but I'm just not going to see the public option patients, then it's actually going to be very difficult for a public option to get the types of prices, to pay the types of prices Medicare gets, and still ensure that providers participate in the plan, and so patients in the public option can actually get care. There are ways to grapple with that problem. If you're willing to basically say to healthcare providers, listen, if there's a public option in the individual market, and you want to serve patients in the individual market, whether they're privately insured or covered by the public option, you've got to sort of take all comers. You can't sort of pick and choose. Well, then introducing a public option really can reduce prices and in turn reduce system-wide costs. That some of that savings accrues directly to consumers, and some of that savings accrues to the federal government in terms of lower subsidy costs that it can then either use to reduce the deficit or reinvest in other efforts to make coverage more affordable. So I think it's on some level, I think my work has not been exactly pro-public option or con-public option. It's what can this tool actually achieve, and how do you need to design it in order to achieve those goals? Yeah.
No, and it's incredibly important work because it's a very nuanced debate, and people have a very black and white view of it without knowing a lot of the specifics, and specifics are important. So, but actually now, Danny, I kind of want to take a more general view of, just looking back. You have been in the trenches for 4 months, and from this initial rocky rollout of the vaccine that everyone pretty much had, to exceeding a lot of people's expectations of where we are at today in terms of vaccination levels. Can you just talk generally about the lessons that you've learned, the things that you got right, how was the coordination with the federal government, and kind of just what happened along the way?
Yeah, I think despite the fact that we're in a relatively good place now, that came at a cost, right? You think about all of the pieces of this response that could have gone better at different stages. And I think there was an absence of a firm federal coordination from the start, whether that was how we managed and then it goes back to some of the comments I was making about what the CDC's role has been, look at the science and make recommendations. It would, I think, have been a very different outcome had the federal government translated that science into actual policy or directives to the states. And I think a lot of that is true in even the logistics of the distribution. I mean, a remarkable thing happened with the amount of money and resource that went into the creation of this vaccine. I think that's one of the things that we really got right. And that was certainly the U.S. was a huge part of that, but a global team effort to get across the finish line with the vaccine. And never before have we had such an effective vaccine done on the time frame that we've seen it produced on. That said, I think there were lots of opportunities for better coordination between the federal government and the states, better decision making that really weighed some of the different dynamics going on in different parts of our country in terms of how how the pandemic was hitting. I mean, I think even pre-vaccination, that was very true. There were probably a lot of needs that could have been better responded to with a much better federally coordinated effort. So over the last 5 months, what are the lessons learned? I do think that managing expectations clearly and having constant and consistent and truthful communication has been a big part of that. I look at the role that Dr. Fauci has played for our country. And I think just having somebody that people are looking to for direction and that are answering very practical questions. Can I hug my grandchild? Do I have to wear a mask in this setting? I mean, he's done daily media, right? And so in many ways, I've emulated that at the state level. I've really tried to be a consistent presence, trying to explain as much of this rollout to the public as possible. But that's been one of the key lessons learned, is the need for over communicating, for real brutal honesty about the fact that we've learned a ton through this, right? We started, I remember, a year ago or so, the guidance was, or some interpretation of the guidance was, when you come home from the grocery store, you got to wipe down each of your items before bringing them into the house.
Yeah,
and,
I did it.
did you? And then a few months later, we're like, actually, this is primarily respiratorily driven. It's a very small number of cases that is transmitted through contact. And that's hard for people. Like when we're shifting back and forth, touch or no touch, mask or no mask, like that's very confusing for the public. And so being able to just over and over say, we're learning with you all. We will let you know as soon as we see new studies, new science, but it's a hard place to be, and so that was one of the biggest lessons learned, was the need to be accessible and transparent about what we know and what we don't know at every stage.
Yeah, no, and I'm glad we're going to wrap up, and I'm really glad that you ended on that point, because it's true. People get frustrated possibly with, the messaging changing, but people need information, constant information in, it's a cliche, but in these uncertain times, that's exactly what people are looking for. And I do think that's I agree. It's one of the more important lessons that we've learned. And I think you touched on something else, which is, we talked about it yesterday. It's important to remember just how impressive and unprecedented this effort was to create vaccines in a way with the speed and success rate that we have not seen in medical history. So there is certainly a lot that was achieved. It's not to overshadow the issues that we will still have and the losses that people experienced, but as you said, there are some incredibly important things, lessons learned, and things that were done right that will hopefully help also down the line with other health crises. And so we are actually we have kind of a good national perspective, great, local perspective. We will be talking more about COVID on the global level, which is also an area where now that really is lagging. We were doing fairly, we've made a lot of progress here in the US, but in the developing world, it's a very different story. So we're going to have folks from WHO, CDC, Ambassador of New Zealand, Cigna, to kind of offer their perspectives on that. So that is coming up at 10:45. First, right after this panel, though, we have Ben Harder of U.S. News and World Reports, Dr. Paul Keckley, of the Keckley Report, and Dr. David Vequist of the Center for Medical Tourism Research. And they're going to talk about how to choose top healthcare, some of the top hospitals, kind of the practical questions that people have, during a pandemic, but really outside the pandemic during normal times, especially for foreign diplomats. So that is coming up right after us. And again, just a reminder, you're welcome to go into the expo booths at any time, or go ahead and network to connect with some of the other participants. And otherwise, though, hang tight. The next panel will be on in a minute. Matt, Danny, thank you so much for joining us, and thank you so much for your insights. We really appreciate it.
Thanks so much for having us.
Take care.